it might be good to make sure that that applies. For example, we talk about type 1 and type 2, and they're very different illnesses, even opposite illnesses. So if you have type 1, don't take the advice for type 2. And if you have type 2, don't take the advice for type 1. These are very different problems here. So making sure that you apply it properly to yourself.
Welcome, everybody. Everybody's flooding on in here. I see the participants going up. First thing you'll recognize is I am not Leslie. Leslie.
What?
Yep.
It's just like her.
Yeah, right.
Except for the hair.
Right. A couple differences there. My name is Anders Barton. I'll introduce myself here a little bit. I share the same name with Joe Barton. That is because he is in fact, my dad. Well, let's see. Yeah, we got people still coming in a little bit. Oh, you know what? So I'm new to this. I haven't done this before. I've never hosted. I need to share this with Facebook. So give me just a second here as I get that set up here.
So today we're going to be talking about the basics, diabetes basics. A lot of people are new every week. And so one of the things that we want to do is periodically discuss the basics. And what we found was as I was discussing the basics, that I would learn new things and go, what about that? And what about that? And so each time something else and goes, oh, that, and something different, even though we're saying the same thing over and over again. So every other week, we talk about the basics of what diabetes is and what it does and why it exists in you. And so are we ready? Are we on Facebook?
Yeah. Yes, we are. Thank you for taking that moment there, Dr. Saunders. Yeah, so we've got our Facebook friends joining in here. I see everybody in the chat. We've got Roger from Virginia, Carolyn from Texas, Robert, hello, Sue and Bob from Texas as well. I actually used to live in Texas for a couple of years. So yeah, with that, I'll just introduce myself real quick. Again, my name is Anders Barton. I'm the son of Joe Barton. About 5 or 6 months ago, I joined the team, and now I am the product development manager. So any new products that we got coming out going forward, I have my hand in up until the launch date. So you let us know if there's anything that you want to see, whether that's information, knowledge-wise, product-wise, and I'm here for that. So that's just a little bit about me. Beforehand, I was down in Texas. I was on the coaching team that a couple of you might have heard from. We give you guys a call after your initial order, and we just help you get set up with whatever program you're in, whether that's the diabetes solution kit, the healthy heart solution kit, the high blood pressure solution kit, whatever it is. We have somebody reach out to you personally to help you set up your game plan. And so that's what I was doing for about 2.5 years. And then, again, just 6 months ago, joined the Barton team. So with that, Dr. Saunders already mentioned a little bit what we're going to be going over. Before we get started, we do have a bit of a disclaimer. Dr. Saunders, do you want to share that?
Yes. Okay. We give a lot of information on here, but it may not apply to you specifically. In order to apply this information properly, it might be good to make sure that that applies. For example, we talk about type 1 and type 2, and they're very different illnesses, even opposite illnesses. So if you have type 1, don't take the advice for type 2. And if you have type 2, don't take the advice for type 1. These are very different problems here. So making sure that you apply it properly to yourself.
Yeah. And even though Dr. Saunders is a doctor, he may not necessarily be your doctor. So we always want to make sure that you're talking anything over with your own doctor as well here. While Dr. Saunders is talking today, you might have questions that pop up in your own mind relating to your situation or maybe somebody that you know. There is a specific part in this Zoom call where you can ask questions and we'll provide answers. go ahead and ask those questions in the Q&A section, not in the chat. Click that Q&A button at the bottom of the Zoom call, and we'll get those answered later in the call. But with that, we'll go ahead and get started on today's topic, which is diabetes basics. So Dr. Saunders, what do we need to know about diabetes? I feel like so often we go to the doctor's office with maybe an issue and they give us a solution, but not necessarily an answer. And a lot of times those solutions aren't long-term solutions. They're just something to treat a symptom. What is diabetes? How does it work? What are the basics that we need to know?
Okay, so if you know what the problem is, then you know what to do about it. If you don't know what the problem is, then you're shooting in the dark. You know, you could try this, oh, that didn't work, try this, that didn't work, try this, that didn't work. And so most of the time, what we're taught in medical school is to shoot in the dark. So if you come in with depression, well, I don't know why you're depressed. Here, try this Prozac. Did that work? No, that didn't work. Okay, try this Effexor. Did that work? No, that didn't work. Try this Zoloft. No, that didn't work. You're just shooting in the dark, essentially. You're being a guinea pig. Well, with diabetes, they're doing the same thing. And you don't need to. You can actually know exactly why you have diabetes, what type it is, and why it's there. So there are several things that you need to know about it. First of all, what is diabetes type 2? Type 2 is too much. That goes along, right? You have type 2, too much. Too much what? Too much sugar, too much fat, too much protein, too much insulin, too much glucose in your blood. It's all toxicity. It's too much of everything. And so the problems with type 2 diabetes do not come from having high blood sugar. That's just the part that's measured. The problems like Alzheimer's disease, neuropathy, amputations of your legs, and heart disease, they don't come from having high blood sugar. They come from having too much insulin. So how do you know how much insulin you have? Well, look at it. Look at your test that you got from the doctor. Did the doctor measure insulin? Rarely. It's a rare, because in medical school, they tell us, oh, don't measure insulin. You don't need to know that. But you need to know that because you need to know if your pancreas is functioning. Why? Because there's two different types of diabetes. You have type 1, where the pancreas doesn't make insulin, and then 2, where the pancreas makes too much insulin. So too much insulin, you become insulin resistant, so it doesn't work. So they're both called diabetes because the insulin isn't working, but one is a lack of insulin and one is insulin resistance. It's not working. So that's why it's really important to know that, because if you have too much insulin and it's not working, then what benefit is there, or what sense does it make for your doctor to prescribe to prescribe insulin for you if you already have too much insulin and it's not working? What, more insulin is going to be better? Well, it might lower your blood sugar briefly, but you're going to become more and more insulin resistant as you add more and more insulin. And I've had people on 100 or 200 units of insulin a day. Just to give you a perspective, the average pancreas will put out between 10 and 20 units a day in a normal person. And so 100 to 200 is 10 times that amount of insulin. So you can imagine that's a lot of insulin. And a lot of that is long-acting insulin. So it's not just the quick-acting, 10 minutes of insulin that you get from your pancreas. It's 10 hours of insulin or 24 hours of insulin. So it's like it's high levels acting for long periods of time. Not a good idea. So if you know you have type 2 and your insulin is high, then you know to say, maybe adding more insulin is not a good idea. So then what do? Well, if you understand why the insulin is there, what causes your body to make insulin? Eating, anything, drinking, anything except water. And if you eat protein, you make insulin. Why? Because insulin actually gets the amino acids from the protein into your cells. you can't get nutrients into your cells without insulin. You have to have it. But when your cells are full and just jam-packed with all this sugar and protein, then the nucleus says, whoa, and actually stops making insulin receptors. So your cells have no insulin receptors. So the insulin comes and goes, oh, no, nothing there, moves on, and it has nowhere to go. So it just goes up and up and up. And that's what insulin resistance is. Those cells have no receptors for it. So it's just sitting around doing nothing. It's swimming around in the blood with nothing to do. And then the blood sugar's going up because you can't get the sugar into your cells. And the pancreas goes, oh my gosh, the blood sugar's going up. I got to make more insulin. And then your pancreas makes more insulin. Can you see why would you want to add insulin to that? Not a good idea. And guess what? Most of those medications that the doctor gives you, except for metformin, almost all of the other ones, I can't think of any that don't, raise insulin levels. They tell your pancreas, they trick your pancreas into making extra insulin. So then that's the same thing though. You already have too much insulin. Why are you wanting to take a pill to tell your pancreas to make more insulin? It just doesn't make any sense. So that's why you need to know what you have, why you have it. Because if you have high insulin levels, type 2, then you want to avoid all those things. And then that's the next question. How do you get it down? Insulin is made every time you eat. So guess what happens if you don't eat? You don't make insulin. It's that simple. That's a really simple way of doing it. What we've put together, if you have the diabetes solution kit, and I hope all of you do, phase 1 of that program is a very low carb diet. Why? Well, because those cells are jam-packed with carbohydrates, and you want to get those carbohydrates out of the cells, and you can use them up, but they're going to pack in more carbohydrates if you have more insulin. So you have to stop putting carbohydrates into cells. And the way to do that is to stop eating them. So the Diabetes Solution Kit gives you a 20-gram carbohydrate diet. That's 20 grams a day. That's not enough carbohydrates to run your body on. Your body needs a lot more than that. Why do we do that? Well, because in starving yourself of carbohydrates, then you have to start using up all of those carbohydrates that you have stored in all your cells. And as you're using it up, then the toxicity level goes down. And then the insulin receptors start being made. And then the insulin starts bringing sugar into your cells. The sugar starts going down. The sugar goes down, then you don't need to make as much insulin. It's just an automatic process, and it's a beautiful process. And many of you have done this, and you know it works because you've done it. So the simple solution is to detox. And by detox, that means don't bring any more of those toxins in that's causing the problem in the first place. And in this case, what we use is a very low carbohydrate diet. Does that make sense?
Yeah. I have a personal question. Well, not personal. Actually, I have a friend who he was diagnosed as, well, type 2 diabetic about 2 months ago. He's turning 25 this month. And then he got re-diagnosed as type 1. I always thought that type 1, you were born with it, and it's not something that you could develop over the years. Is type 1, are you able to develop that, or is it always type 2 when it's later down the road?
So type 1 is where you don't make insulin. The pancreas isn't making insulin. So yes, some children are born with that. And they used to call it childhood onset diabetes would be type 1. And adult onset diabetes was type 2. But now we've been seeing children with type 2 and adults with type 1. So yeah, in the old days, it was always known as that, childhood. But it's just all mixed around because there's a lot going on, a lot of different things. Why a pancreas would not make insulin. And so some people are getting autoimmune diseases, for example, and their pancreas shuts down and stops making insulin because they have antibodies against either the insulin or the cells that are making the insulin. So that's an autoimmune disease that can happen even in adulthood. But, you know, in someone like that, I would test the insulin level, test the C-peptide level, test for autoantibodies, and do these tests to see why. Because if someone didn't have diabetes and they do now, there's a reason that changed. And knowing why it changed, you can reverse it.
So forgive me if I'm mispronouncing this, but Iman from, I think he said he was from Brazil earlier, is asking about some tingling that's going on in his toes, especially when he takes off his compression socks. And then sometimes some throbbing that's going on, a throbbing pain and a bunion in his foot. Is that caused by diabetes? What are usually the issues there?
It can be. Oh, there are several issues here to look at. One is neuropathy. The nerves, because the longest nerves in your body go from your spinal cord all the way down to your toes. Those are such long nerves that they're really susceptible to either blood flow problems or energy problems. And type 2 diabetes, one of the problems is a lack of energy, that you aren't able to efficiently make the energy in your nerve cells. They may not be getting enough blood flow. So there's two issues here. One is neuropathy, and it's really important to get your insulin levels down so you don't increase that neuropathy. So yeah, that's really important. And that's where you get the tingling in your feet or numbness or burning pain sensations. And then the other part is blood flow and the throbbing feeling. The bunion is a joint problem. That's an arthritis kind of issue that you may need actually surgery to repair that. And if that's inflamed, then you may feel throbbing from that. But getting the blood flow back is really important. And one of the things that we've done is we have a supplement called Nervala. And it comes from nerve ALA, alpha lipoic acid, and it also has benfotiamine. And the benfotiamine in that repairs the lining of the blood vessels so that you get better blood flow. The blood flow happens. The blood flow decreases when there's damage to the lining, and the benfotiamine is actually vitamin B1. And vitamin B1, it turns out, is really important for getting that blood flow.
Sorry about that. I ran out of the room quick to grab the Nervala. I'm not used to this, so I gotta make sure I'm going the right way. So this is what Nervala looks like. You can go on to, I believe, bartonnutrition.com and or store.bartonnutrition.com, and I'll throw that in the chat here in a minute. Let's see. We have a question about Berberine, which is another one of our products here. How does that affect blood sugar? Does it work similarly to any drug? In what ways is it more beneficial than certain drugs? And how much of it should we take on a daily basis?
Okay, so Berberine actually is very similar to Metformin in the way it works. So a Metformin blocks your ability for your mitochondria to use sugar for energy, and kind of it increases what's called cyclic AMP and forces the body to burn fat for energy. Berberine, it turns out, forces the body to burn fat for energy, but it works in a different way. And so it doesn't have the side effects. So that's why it's more beneficial than Metformin. And head to head, it's about the same as far as its effectiveness. But remember, don't consider a drug or a vitamin or an herb. I don't care who sells it. I don't care if it's Barton Publishing selling it or Barton Nutrition selling it. Don't look at that as that's going to fix your problem. That does not fix your problem. If you have insulin resistance, Berberine is going to help you, but it's not going to fix the problem. You still need to do phase 1 of the program. So the program is the fix, and the Berberine is the help, and the Nervala is a help, and the Synachroma is a help. Those are helps, but they're not the fix for your problem. Oh, and the amount, he asked the amount too. Berberine should be about 500 milligrams. If you have diabetes, 3 times a day is better. If you just want to control, prevention, then twice a day is fine. Berberine is shorter acting than metformin, so it should really be taken 2 or 3 times a day.
Yeah. Yeah. And just reading on the back of this Berberine bottle, it says take 2 capsules once a day, which would be, it looks like there's 800 milligrams of Berberine HCl in this, in a serving size. So, and that would, what you were saying towards the end there about supplements not being the fix or the answer, it's really in the program and the lifestyle. That kind of goes to, I think I might be mispronouncing this again, I apologize, either Eloy or Eloy, asking about, they're taking fiber greens, they're taking Berberine, healthy gut, Niagara, Cinechroma, all these things that we recommend. And they've been doing so for about 3 months now, but they're still pre-diabetic, asking why that is. What would you say to somebody who's taken all these but might not be seeing those results in the first couple months?
Because the problem is different than what those supplements address. So the herbs and the supplements are helps, but they're not addressing the problem. Remember, the problem we just talked about is those cells are jam-packed full of sugar. And so the supplements don't address those overloaded cells. And that's where the problem comes in. That unless you address the problem, it's not going to be fixed at all. So that's why phase 1 of the program, you lower the carbs that you take in so that your body has to use up the carbs that are filling the cells, and then everything relaxes and everything starts working again.
Yeah. Yeah. And I think that just attests to why it's so important to not only, take in what's healthy, but also kind of on the opposite side, take out the things that aren't healthy. It's a both and a give and take. Yeah. How much does, maybe it even does it, how much does blood pressure correlate with your blood sugar and diabetes? And then what does a healthy blood pressure level look like?
That's a great question. Okay. So that's one of the issues, like in the UKPDS study, that's the United Kingdom Prospective Diabetes Study. So that UKPDS showed that people who were given medications to drop their blood pressure, to drop their blood sugar, to drop their cholesterol, they're on medications, all of their numbers are better. Their blood sugar's better, their cholesterol's better, their blood pressure's better. And they had a higher rate of strokes, heart attacks, amputations, blindness. All of the complications of diabetes were increased in the people who had better numbers with the drugs. Why is that? Well, there are several reasons for that. If you are taking drugs to lower your blood pressure, you're decreasing the perfusion. So think about it this way. None of you have ever been to McDonald's, but if you had ever been to McDonald's, just like, I've never been there, obviously. No. So, but when you're trying to suck that triple thick strawberry shake through a straw, it's really hard to get through the straw. Think of that, of your blood trying to get through these little teeny capillaries. They're so small, they're microscopic. And think of how thick the blood has to go through that little teeny capillary. You have to have enough pressure. So you take a blood pressure medication, it drops your blood pressure, what happens? Then you don't get any blood going through those arteries anymore, the capillaries. It just stops. So then what happens? Well, then your legs get dusky, and then you get ulcers, and then you end up having to have an amputation because you get an infection and you can't heal it because you don't have any blood flow. Then you get Alzheimer's disease. Why do you get Alzheimer's disease? Because you're not getting any energy into your brain because you don't have enough blood flow. So you're going backwards if you're dropping your blood pressure. So the question was, what is the optimum blood pressure? And that's been studied. So if you look at death rate versus blood pressure, the perfect systolic blood pressure is between 140 and 150. So you want 140 something is the perfect blood pressure. 150 something is okay. But if you drop below 120, the death rate starts going up pretty fast. And it goes, by the time you're at 110 blood pressure, your death rate is double what somebody is who's at 140. That it's a big difference. And so you don't want to have low blood pressure, especially if you have diabetes. Why? Because insulin raises blood pressure. And so not by itself, but indirectly raises blood pressure. So the blood pressure goes up when you have decreased perfusion to the brain. When you don't have enough blood flowing into your brain says, hey, I need more pressure here. And it raises the blood pressure. So then what happens if you take a pill to drop the blood pressure? Well, then you get less blood flow to your brain. What do you get? Alzheimer's disease and dementia and all of the neuropathy, all the brain problems. So just be really careful. Your optimum blood pressure is between 140 and 150. And then the diastolic should be between 70 and 80. That is like the longest lived people.
And does that vary depending on age? Because I remember growing up, I always hearing like 120 over 80 was perfect. Does that affect it at all or no?
Probably to some extent. Young women, because of their hormone status, are generally going to have lower blood pressure. So 110 over 70 wouldn't be unusual for young women. But because there's not a correlation in the younger people with the death rate and the blood pressure, then the studies are generally done on people over 50 to over 65. So yeah, there is a difference in age.
Yeah, that makes sense. Let's see here. How is popcorn as an occasional snack?
I love popcorn. It's a terrible snack. It's like pure sugar, it's all that fluffy goodness is just starch. That's all it is. So look at your 20 grams and count. Popcorn, you're not going to get very much popcorn, although it does fluff up a lot. You're not going to get very much popcorn in your 20 gram allowance. So I don't know. I would avoid it if you're in phase 1 because it's going to cause a rapid rise in blood sugar. Yep. Especially, when you put butter on it. The butter is oil, and oil makes you insulin resistant. And so then you have the combination of insulin resistance and adding on sugar. And so it can drive up your sugar a lot and make your insulin go up a lot.
Yep. While we're on a low carb diet, is it okay to combine the low carb diet with taking Cinechroma?
Yes. Oh, absolutely. Synacroma is just food, right? It's selenium, chromium, vanadium, vitamin D, vitamin K, flavored with cinnamon. That's all it is. So just think of it like a food. The Cinechroma is not to lower your blood sugar. That's not what it does. That's not even its purpose. Its purpose is to make sure that when you're on the program, that you get good results. Because if you're deficient in any of those nutrients, then you're not going to use blood sugar very easily, very well. And so you're not going to get good, easy results when you're on phase 1. So the program is phase 1. So the book is the thing. The supplement is the help.
Yep. All right, let's see here. In an earlier webinar, Dr. Saunders, you had recommended that berberine should be taken maybe 5 days on and then 2 days off. Should this be followed when first starting to take berberine?
Okay, that's a great question. Yeah. So what I was talking about in the 5 days on, 2 days off, I was talking about generally herbs when they're studied and vitamins. You need to take a couple of days off for it to work, for it to continue to work, and that's for supplementation. That's for more long term. If you're treating something, you may need it every single day. So in the case of somebody who has high blood sugar, they're using berberine to help get the blood sugar down. then every day would be a better idea.
Okay. All right. Let's see here. Oh, we got a little testimony here from Jerry Ayres. Might be pronouncing that again. I'm sorry if I am. It took 2 months, but I got rid of these symptoms taking Nervala. So it's great to hear. Let's see, from Jeffrey, is it possible to go from type 2 to type 1 for any reason?
Yes. In fact, it's not that uncommon actually for people who are type 2 as time goes on, for their pancreas to stop making insulin. So type 1 is where the pancreas stops making insulin. Type 2 is when it's making too much insulin and you're resistant to the insulin. So, yes, the amount of insulin you make could decline over time for various reasons, one of which we already talked about, an autoimmune disease. If you have inflammation in the pancreas, or antibodies against either insulin or insulin receptors, or the islet cells that are making the insulin. So yes, and you know what's really interesting? This is weird. Some people, because of their vagus nerve actually shuts off insulin production. And why that is, nobody's quite sure. In fact, there was they found it in a group of I think it was rats, where they were doing a study, and they found that these rats had zero insulin output. They were type 1 diabetes completely, and so they injected capsaicin, which is the stuff in pepper cream. They injected capsaicin to block the vagus nerve going to the pancreas. And all of a sudden, boom, insulin started being made right away. The brain had shut off the insulin. And so they were diabetic because of the brain telling the pancreas, don't make any insulin. And so, but when they shut off the nerve to the brain, the vagus nerve, all of a sudden it just started making insulin again. So there's other reasons, things that, like, why would the brain tell the pancreas to be type 1 diabetes? I don't know. It doesn't make any sense to me.
Vincent is asking, can fasting also help on a low carb diet?
Oh my gosh, fasting. Okay, there is practically nothing in the modern world that fasting doesn't cure. If you look at all the inflammatory conditions, if you want to live long, if you want to not have diabetes, fasting is by far the single best treatment you could do for just about anything in the world, any problem that you may have. Fasting fixes the immune system. It fixes the metabolism. So people who have autoimmune diseases, fasting is helpful. There's a whole bunch of ways to fast. And so some people eat 1 meal a day. Some people have alternate day fasts where they eat whatever their 3 meals one day, and then the next day they don't eat at all, and then the next day they eat 3 meals, the next day. So alternate day fasting. You can have a 5-hour window of eating that you can move around in that day. So today I'm eating breakfast and lunch. Tomorrow I'm eating lunch and dinner, or something like that. That is one way of doing it. Intermittent fasting. I had somebody who had arthritis, and he had ankylosing spondylitis, which is a really bad type of arthritis in the back, where if you've seen those old people that are curled over and can't look up, that's usually from that kind of thing. It's a chronic inflammation of the back, and he was just fine, but he had to fast for 10 days. So he would do water only for 10 days once a year. And every year he would just, okay, it's time for my 10-day fast. And he would fast for 10 days to get all that inflammation down. So there are various ways of doing it. And so that's the long answer to your simple question of, can fasting help? Absolutely, it helps.
Yeah. Sounds like I might need to start fasting a little bit more for my autoimmune disorders. Sherry's asking, she's taken a couple of different drugs, Metformin, Jardiance, and a statin, and she's just feeling exhausted all the time, very tired. Is it possible that any of these drugs are contributing to her fatigue?
Totally possible. Oh my gosh. Last week, I had someone on those medications and then also a beta blocker. And he had come to me and he says, I can barely get around. I'm so tired all the time. I walk up the hill and I'm winded. I can't even get up a flight of stairs. You know, he was like that, really fatigued. So that was a couple of months ago I first saw him. So last week we talked again, and he said, "Oh my gosh, I feel great." I said, "What'd you do?" He said, "I just quit all the pills." And I'm like, "What? You can't do that." He goes, he says, "Well, I did. Too late. I already did, and I already feel great." So the answer is absolutely yes. Why? Well, because the statin blocks your coenzyme Q10, which is necessary for making energy. The Jardiance causes you to make more insulin, and the metformin blocks your muscle cells from using sugar for energy. So all of those are energy wasting or energy sapping drugs.
Okay. Sorry, I'm just scrolling through all these Q&As. You got a lot of good questions, and feel free as well to share any testimonies that you get or any questions that you have. And you can share the testimonies in the chat, just to help encourage other people who are on this webinar, sharing your positive results of how this has affected your life for the better. And then, yeah, again, if you have any questions, throw them in the Q&A there.
I was reading a book called Fast, Feast, Repeat. Jen Stevens is the name. And it's actually a good book. She's not a doctor. But she's a PhD, and she's looked into this quite a bit, and she is knowledgeable. And that was a great book. It was because it gives you a lot of options for fasting. I like that.
Mm-hmm. Yeah. All right. Jerry has a question about an potentially old wives' tale. Years ago, my aunt, who's a nurse, told me that taking 81 milligrams of aspirin at bedtime to avoid a heart attack. Is this an old wives' tale or actually helpful?
It can be actually helpful. So there is good evidence to show that it does prevent heart attacks. But there's a problem with it. See, everything has a side effect, double-edged sword, right? So the prevention of heart attacks is a small effect of taking an 81 milligram aspirin every day, where a larger downside is bleeding. So because it blocks the platelets and stops bleed and stops the clotting factors, that you're more likely to bleed, and it also inhibits the lining of your stomach protection, so that you're more likely to get bleeding ulcers. So, and the chances of bleeding ulcers are greater than the benefit you get from preventing heart attacks. So yeah, it's good and it works, but it's definitely not. It's not something everybody should do. If somebody is like that, they have clotting problems, like they're getting clots in their veins and stuff, and aspirin is probably more worth it than somebody who doesn't have those issues.
So you've talked a lot about how the program, how you need to do the program and the lifestyle, the phase 1, in order to really see the results that you're looking for. It's not necessarily taking these supplements that are going to reverse your diabetes, but ultimately making the lifestyle change. If somebody does choose to take the supplements, the Synachroma, in order to help, and they've been taking it for less than a week, how do they know that the supplement, the Cinechroma specifically, is doing what it's supposed to do? What are some things they should be able to see?
Well, nothing. In fact, ideally, you should see nothing. But the reason for the Synachroma is because those nutrients that are in Synachroma are common deficiencies. But not everybody's deficient in all of them, and many people are not going to be deficient in any of them. But they're to help you along the path of when you're on phase 1 of the program. So let's take the scenario and say, okay, I'm doing phase 1 of the program and I'm eating a 20-gram carbohydrate diet, and I'm eating really carefully, and I'm eating a lot of fibers. So I mean, all the free foods that are on there, the broccoli and spinach and lettuce and cabbage and all that stuff. But I get enough of that. And so I'm eating a really good diet. And so why am I going to take Synachroma? It's a help. It's a common deficiency. So you could test first. I do tests on a lot of people, and I test for what is your chromium levels, what's your vanadium levels, what are your vitamin D levels. So I test all of those things, and I say, okay, you need vitamin D and you need chromium, your vanadium's okay. Well, you can take Cinechroma. And so that's what it is. It's not the idea that I'm going to take a pill and see some results or benefits from it. But you could, if you want to test for the nutrients and then take the pill, and then, 6 months later, repeat the test, you go, aha, I'm no longer deficient.
Yeah.
That works.
Yeah. All right. Connie's asking about those tests that you mentioned. I don't remember. I think there's like 10 of them or something that you recommend people get. Could you list those off for the blood sugar numbers?
Oh yeah, no, the simple ones there's actually only 4 tests that are the ones that the doctors don't usually do. Some of them they do. So the blood glucose and hemoglobin A1C, that's what most people get. And then C-peptide, that's C-peptide. And then the insulin levels. So those are the 4 tests that you need. Those are the basic tests to see whether you're type 1, type 2, and how much excess insulin you have, for example, or how deficient you are in insulin. So I had someone today, for example, who came in, and her hemoglobin A1C is pre-diabetic. So I'm like, pre-diabetic, but her insulin level was 2, and 2 is a low insulin level. So she has a relatively high blood sugar with a low insulin. And so now I need to do further studies. So she needs a glucose tolerance test with insulin to see if her pancreas is even working, because all I see right now is just this very low insulin level and a slightly high blood sugar.
So somebody's current situation right now, they're a skinny diabetic and they can't gain weight. What advice would you have for them?
Okay, if you're a skinny diabetic, then you probably aren't making insulin. In that case, then you need the insulin C-peptide, and I would even consider doing the 3-hour glucose tolerance test with insulin. So they draw insulin at each time they draw the blood sugar, they're drawing an insulin level too. So that can tell you what the blood sugar is doing after you eat, and then what the insulin's doing. Because if the insulin is, when you first start out 5, and it stays 5, and your blood sugar goes up to 150, then you've got an issue with your pancreas making enough insulin. If you don't make enough insulin, you can't get either glucose or amino acids into your cells. Your cells are going to die of starvation if you don't make enough insulin. So it's really important that you know whether you're type 1 or type 2. First off, especially if you're skinny, because that means you probably aren't making insulin, or you're really resistant to it in another way, like autoimmune disease or something.
Yep. So somebody's asking for those tests again. Could you list them off once more? And I'm going to throw them in the chat. Just
okay.
So I can those.
Okay. Glucose, hemoglobin A1C. So just A1C is what they call it. And then C-peptide, that's C-peptide, and then insulin level.
All right. There, that's in the chat now. I just threw it in there. So anybody who's looking for those tests so that they can get those done for themselves, there they are. Does berberine block muscle energy?
Probably not. The reason I say probably is because I've been looking at the research there to find out if it is, but I don't see it. And it doesn't block the mitochondria the way the metformin does. So it doesn't have that effect. Although it does block glucose metabolism. So I can say probably not, but I can't be too sure.
And then same, so Roy's asking as well for metformin. Can metformin cause muscle loss?
Oh yeah, it can. So what happens is you have this terrible combination of really high insulin levels block your ability to use fat for energy. And then you take metformin and that blocks your sugar metabolism, the glucose metabolism. So now you have a muscle cell that can't use glucose and can't use fat. So what's left? So that's where you can lose muscle cells, and actually, it's been shown that liver cells can be damaged too.
Okay. Do we have any iron supplements? I don't think we do. No, I don't know that we do have any iron supplements.
So iron is not commonly needed most of the time. What I recommend when people are low in iron, the first thing I recommend is a vitamin C. So you just take a 500 or 1,000 milligram vitamin C with each meal. And the vitamin C, the ascorbic acid, will make the ferrous ascorbate, which is really easily absorbed. So all the iron that's in your food will be easily absorbed if you're taking vitamin C. And it's a much better way of doing it than taking iron pills.
Very good. Just going through the questions, seeing if we have any here. So Edward is making good progress, slowing his A1C down. He's down to 6.6 from 8.9 a year ago. He's off of metformin. They added Glimepiride, Berberine, and ribose. Any thoughts on ribose? How much and what time to take? Anything like that?
Okay. Glimepiride, Glimepiride, or glipizide. Either one of those tricks your pancreas into making more insulin, is the way that works. And the other ones, the berberine is great. That acts kind of like the metformin. So I wouldn't take the glimepiride or glipizide, whichever one of those it is. And then what was the berberine, and what was the last one?
Ribose.
Oh, ribose, yeah. So actually, D-ribose is kind of really important for building up your mitochondria, which is the powerhouse. Those are the little bacteria that live in your cells that make the energy. That's the power station for your cells. And ribose is really important for increasing those, because they have to reproduce and they need to make RNA, DNA, which requires ribose. So yeah, the ribose is a good idea, and berberine is a good idea, and the other one is not.
So this is a general question. I don't know necessarily if it relates to diabetes. I suppose you'll know. But Ted is asking, what happens if too much iron is in your blood?
Okay, too much iron in your blood is hemochromatosis. And iron is damaging. We think of iron, oh, that's really important. And that's one reason why we don't have an iron supplement. Iron is an irritant to tissues. It's an oxidant. It causes oxidation, oxidative damage. It damages DNA, and it damages anything it comes in contact with. So your body makes a protein called ferritin to grab onto iron and hold on to it. So there's no free iron in your blood at all. So when your iron levels are too high, you get more oxidative damage generally. And that can lead to things like liver disease, death of liver cells. Hepatitis is what it's called, but not infectious. This is from toxin from it's chemical hepatitis. But it can also damage the pancreas. So you can get diabetes from that. And so, yeah, hemochromatosis is not a good thing. And so people who have that, they have to get phlebotomy. They have to go and have their blood drawn, and they take, it's funny, when people have this, that you should think that they would just go down to the Red Cross and give blood, right, periodically. But if they go into the Red Cross and they say, I have hemochromatosis and I need my blood taken out, the Red Cross has to say, nope, we can't do it, because we can't treat an illness. So then you have to go to the hospital, and the hospital takes your blood, they take a unit of blood and throw it in the trash. Even though it's perfectly good blood, just has a lot of extra iron in it.
So Shiana is saying, I've taken Cinechroma since January this year. I'm on day 29 of phase 1 of the diabetes solution kit. My blood sugar has been great, 96, 93. But my latest D3 level is as high as 104 due to Cinechroma having 5,000 IU of D3. My PCP doctor requested me to stop taking any supplement with D3. Do I stop taking Cinechroma? What should I do?
Okay, you can stop taking Synacroma. And that's fine. But what I would do is I would take it twice a week. Yeah, you know, you don't need that much, but it'll still be helpful, and you'll still get all the benefits of the nutrients. So it's not like a drug that you have to take it every day. These are nutrients, and your body just takes them up as you need them. And if you take it twice a week, then you're still getting all the benefits without any of the risks.
Yeah, that's that's something I've always wondered, with the supplements. I remember when the pandemic started back in 2020 of March, I think you had recommended to take 10, or maybe you didn't, or my dad, somebody recommended taking 10 pills of Synachroma or 10 capsules of Synachroma. And it made me think is this something that you can overdose on? And so I guess that would be my question. Can you overdose on supplements?
Yes. Specifically Synachroma, there's two nutrients in there that you can overdose on. So if you get really high vitamin D, then you absorb more calcium, then you get hypercalcemia, and then you get nausea. It's not a fun thing. And the other one is selenium. You can actually get too much selenium, and it's not good for you, and it can increase heart risk for cardiomyopathy and cancer risk. So you don't want to be toxic on selenium.
Mm. Do you know somebody? Go ahead.
Yeah, go ahead.
Okay. Somebody's asking, do you have any idea where in London somebody can get these tests, the 4 tests that we mentioned earlier?
Oh my gosh, I was just in London. I love that place.
There you go.
No, I don't know. Any lab can do those tests. These are not unusual tests. See, these are normal tests that any lab that does, if they do glucose testing, then they could do these tests. So there isn't anything about these tests that's unusual or abnormal. So whatever lab you have, whatever lab you would use. In fact, there's, I don't know if it's in England, but in the United States, there's anylab.com. And they'll send you out a kit, and you can either do a blood spot test or have your blood drawn and send it to them, and they'll do any lab for you at all.
All right. Well, Dr. Saunders does have a clinic that he has to run. So we'll ask one last question, and then we'll let you out of here, Dr. Saunders. Cleansing your liver and pancreas, does that help your diabetes? And if so, what's a good way to accomplish that? Okay.
Excellent question. We're going to probably do a whole webinar on this. Let's spend an hour on cleanse. So cleanse, detox, there is one thing that cleanses the body, and that is when you're not eating. When your stomach is empty, you start cleansing. If you put something in your stomach, you stop cleansing. And that's the way the system works. You have a hormone called ghrelin that is only made when your stomach is empty, and that means no water, nothing. It has to be literally empty. If you're chewing gum, it doesn't work. If you're taking breath mints, it doesn't work. You actually have to have an empty stomach. And when your stomach is empty and you make ghrelin, you start a process of cleansing. And the cleansing, by the time you reach about 24 hours with an empty stomach, you're into autophagy. Autophagy means literally eating yourself. And what does that mean? Well, you're not eating any food, so you have to get food from somewhere. So you start taking it out of your fat cells. You take your fat out of your fat cells. You take your cholesterol out of your arteries. You take your proteins, all that extra trash proteins that are laying around, and you clean out all the you clean out all the cells, all the dead cells, the bad cells, the infected cells. That's autophagy. You're cleaning everything out. The only way you clean out is when you have an empty stomach. So don't let anybody tell you that they're going to give you some pills to cleanse or give you a kit to cleanse or whatever, you eat this and eat that. if you're not putting anything in your stomach or anything in your mouth, then that's when you're cleansing. So yes, that really helps diabetes, like a ton.
All right. Good deal. Well, it's just past 2:00 here Central Time. So thank you, Dr. Saunders.
Thank you
for answering all of our questions. Thank you, everybody who attended. Saunders, if you need to, oh, and he's gone. All right. There was one question I wanted to address before we let you all go. Connie, you were asking, the webinar starts at 2 p.m. Eastern time, but you're not able to connect until 2 p.m. or 2:10 or so. And you wanted me to answer it off the air, but I'm just going to answer it quick here if you're still here. That is because sometimes we just run a little late or we start a little late. So it is listed for 2:10. We want to make sure everybody's getting in here. The participants are joining up. And then right around 2:10, we'll start the webinar, or a little bit earlier, sometimes 2:05. It just depends once Saunders gets in. So thank you guys again. Have a blessed day. We'll see you next time.